Well, welcome to the session. We're having another session on machines, and those who've been here yesterday might recognize the odd argument here or there. I'm the moderator, so today I'm not talking. I would like to remind you that there is an SMS number that you can call if you want to ask a question without getting up out of your chair. And so let's start with the session. The car on the left is actually blue because I didn't know we had green and blue, so imagine it's green, okay? I'm not colorblind. We start with Ivan Fisser, on the smaller the better. Now, is your microphone working?
I think it's on.
Yeah.
Why do I advocate the micro-incision vitrectomy surgery? I told you yesterday, I did not use them routinely because of some financial concern and due to my trust in a better accuracy of the 20 gauge. But when I started with the 25 gauge plus 4 years ago, I realized that it is even more beneficial than Alcon declared. And my trust in a better accuracy of 20 gauge proved to be wrong. I performed over 1,400 surgeries with a higher success than before. We know the advantages of the cutter. It has adjustable duty cycle and it has a fast cutting rate, but the speed is not an advantage for me. It's mainly the smaller flow which makes the surgery safer, because I believe that the smaller the gauge, the smaller the required flow, thus the smaller the risk of retina incarceration. So even if the pulsatile traction is smaller in small gauge surgery, important is especially the play with the aspiration and the cutting rate. And important for me is the pedal function, which is called 3D. And I want to stress that my foot during the surgery is as important as my hand. I want to mention that times have changed since the birth of the EVRS. The Constellation has no more that type of classical venturi with the large aspiration chamber, but it is a pump of a new generation which enables even vacuum control with a flow limiting and also flow control with vacuum limiting, but only for 20 gauge surgery and for cataract surgery. I recently tried a machine with a peristaltic pump only, and I have to say that the roller principle provides a stable and safe flow. However, it is rather slow and lazy. It was a good machine, but we need something more dynamic, and we need this. And the modern venturi pump enables much faster vitreous dissection with the same level of safety, even when we are working on the surface of detached retina, because the decreased air space volume in the aspiration chamber, which is the secret, shortens the aspiration response time. Other advantages of the cutter, the port is placed close to the tip. It enables you to work close to the retina with less traction, with lower risk of retinotomy. The best feature of Constellation ever is the excellent IOP control, and it enables to work with lower intraocular pressure from 15 to 20 millimeters mercury. This is measured by Doppler, and we know that low intraocular pressure prevents corneal edema, prevents retina and vitreous incarceration, helps identify bleeding, and leads to lower risk of retinal detachment. What is my concern is the possible incarceration of vitreous with secondary tears and secondary retinal detachment after the surgery. So when I switched from 20 to 25, I had a fear from frequent retinal detachments. However, fortunately, this did not happen because I don't know why. Perhaps the incarceration of the vitreous fibers is minimal due to small gauge and to the tangential scleral tunnel, and also due to the minimal intraocular pressure. So using 25 gauge surgery, in my hands. Post-vitrectomy retinal detachment is very rare. We know the cosmetic advantages of this surgery, but we don't care so much. More important are the surgical advantages. You need a single instrument for vitrectomy, segmentation, delamination, retinectomy, drainage of subretinal fluid, and fluid exchange. Almost you do not need the scissors, backflush cannula, sometimes even not the forceps, because you can perform the vacuum peeling. Thus, thanks to the construction of the vitrectomy probe, thanks to the excellent intraocular pressure control, thanks to the fine control of frequency and vacuum, using the 3D foot pedal makes vitrectomy safer. 23-gauge instruments have some of these advantages too, but I believe that the 25 is safer because of better closure of sclerotomies without stitches. 1 year ago, I performed my first surgery with 27-gauge. The surgery was very similar to 25. I performed even retinal detachment. The advantages were that the H+ knife is fabulous, it is very sharp, and it so easily goes into the sclera, and also the manipulation with the membranes is even more delicate. The fluidics is excellent, and the sclerotomies are even smaller, so they are watertight. So I believe that 25 or 27-gauge surgery has a lower risk of involuntary retinotomy. Thus, it has a lower risk of vitreous incarceration with later peripheral breaks and detachment. And so it leads to faster and safer removal of adhering vitreous, as well as all kinds of membranes without changing of instruments. So my take-home message is that this micro-incision vitrectomy surgery, both 25 and 27-gauge technique, not only are equally safe as previous techniques, 20 gauge, using the peristaltic pump, but it is a real progress.
Thank you. Since we're staying in the same subject on both sides of the green and the red, my suggestion is that we continue with the talks and then we have a very thorough discussion towards the end if everybody's agreed with that. Which means we continue with Hyun Song.
Thank you for your good pronunciation.
Did I get that right?
Yes.
Good.
Yes, good, really good. Today we are here together to discuss about the pros and cons of the each vitrectomy system. Today, so as a member of Alcon team, I would like to introduce my study evaluating in vivo IOP fluctuation using constellation compared with the ocular system. As you know, the intraocular pressure fluctuation can cause many severe complications. In case of hypotensive IOP, anterior chamber hemorrhage and partial ocular collapse might be happened. In case of hypertensive IOP, ischemic optic neuropathy could be happens, especially in patients with severe uncontrolled diabetic patient. A new microincisional vitrectomy system with the valve trocar system also very good in these days to stabilize the IOP in hypotensive case. However, the valve trocar system can aggravate the hypertensive IOP by preventing the fluid leakage from around the trocar. So we evaluated the prospective case study analyzing the 61 eyes. 32 eyes were assigned to accuracy and 29 eyes was constellation. After preparing the 25-gauge vitrectomy with valve trocar, we added a 23-gauge trocar and connected to the arterial blood pressure monitoring kit and coupled to the blood pressure readers. And as you can see, during vitrectomy, we can check the real-time IOP fluctuation. In this case, it was accuracy, and there were the severe IOP drop until 7 millimeter mercury. When we see an IOP change with two different vitrectomy systems during co-vitrectomy, in accuracy case, we saw a minus 8.7 millimeter mercury during using the Accurus, but the constellation was so stable during the core vitrectomy. However, when we see a maximal IOP change during the all procedures, the blue line is constellation and red line is Accurus. And as you can see, during the vitrectomy, constellation was so stable compared with the Accurus. However, the IOP surge was frequently observed during the peripheral depression and intravitreal injection of PFCL and anti-VEGF injection. We have to know about the main mechanism of the hypotensive IOP using the accuracy is because of pressure gradient can be happened because of the Bartle site. In constellation, direct connection between the eye and pressurized cassette can prevent the IOP drops. However, the accuracy is not. So as you saw, I wanted to suggest that IOP drop can be prevented using an active IOP control such as the constellation. However, we cannot prevent the IOP surge using a constellation as well. So we have to be very careful not to, when we do a IOP surgery procedure using a constellation. And as you know, the bent system can prevent the IOP surgery during the vitrectomy. However, the bent system is very passive way, and we cannot use the bent system in all the procedures. So I would like to recommend the machine company to develop the active type negative IOP controlling system for the future. Thank you.
Thank you, Hyun-sung. Can I ask a question? I mean, after all the amazing engineering that's gone into the constellation, it is surprising that there is so little difference between the machines. Francois, you agree with that?
A little bit.
Create some surprise, but
Okay.
why not?
Francois, continue, please.
As I belong to Alcon team, I just want to share with you some concern about standards. And I want to help to choose what standard to have in an operating theater, as we consider that we can't have any standards in any operating room available. The evolution of vitrectomy standards go to reduce surgical burden and minimizing useless wound trauma. Miniaturization, we need miniaturization without losing efficiency. And at the early phase of the 25 gauge, we were a little bit disappointed by this new standard, which was too flexible, and the new vitrectomy machine were not available at this time at the beginning of the 25 standards. And of course, 23 gauge was the learning standard for microincision vitrectomy surgery before new vitrectomy system become available. It was a good compromise in stiffness, time sparing related to lower flow rate, efficiency to remove tight vitreous strands, epiretinal membrane, denser hemorrhage or clots, and it reduced greatly the difference in surgical habit compared to 20 gauge. Now the time changed and the 25 gauge increased drastically in our practice and represent now more than 90% of all cases done in my institution. Why have we this 25 gauge supremacy? Because it's the time of the new vitrectomy system. And we have available efficient and safe system in all situations. we learn to use this Swiss knife technology of the new vitreous cutter. You can aspirate, inject, you can peel membrane, you can do the vitrectomy, you can let your scissors in the box and use only the vitreous cutter during even a complicated retinal detachment surgery with PVR or in diabetic retinopathy. We get better stiffness instrument. With 25, we don't have any restriction for tamponade. We can use silicone. We have always a lot of tools available, and the price go down. And the system, the 25 system, is efficient and safe in all situations. Flow rates enhanced by combination of high speed cut rate and the maintenance of a high duty cycle resulting in time sparing. We probably get less iatrogenic tears with more protection of the vitreous base from mechanical traction by the small microcannula, and we exert less traction relating to high cut rate, and because of greater fluidic stability, we probably have less incarceration. I don't want to come back to the vitreous cutter, but you can use it in all directions. On this video, you can see that with the 25, you can do exactly what you want in nearly all pathology. In a severe PVR, as on the superior video, or even on for macular surgery, you can inject blue through the vitreous cutter. You can exchange and aspirate all liquid PFCL with the cutter until the end of the exchange. You can dissect also membrane in diabetic retinopathy. It doesn't work. I can't change. Can you change the slide for me? Yes. And now, why considering switch between 25 and 27? A lot of surgeons show that it's nearly the same, and you can do a lot of pathology with the 27 gauge, even retinal detachment. For me, I think that we have really the same feeling with the two instruments. In 27 gauge, of course, you do a smaller one trauma. You have nearly the same stiffness, similar use of high cut rate, shorter membrane attraction distance, limiting disturbance of surrounding tissue, and similar close port from the end of the probe, very short, and the same multimodal use of the vitrectomy probe. Cons, it's important to point out that we need higher level of vacuum. And also, we get less gripping force with the forceps. Using silicone is boring. And another important point is that we have a limited access to the vitreous base in specific case due to the probe's weakness, especially in preeminent orbits. In poor local anesthesia, you can't create a limitation of the movement by the instrument. And also, we have limited number of tools, and the probe available is not enough long to access to the posterior pole in a high myopic case. Just this video, but yes, it's just to show the efficiency of the 27 gauge, even in severe vitreous hemorrhage. You can remove the hemorrhage nearly in the same time that you can do it in 25 gauge. Can I have the next, please? Just it's not.
Wait for the video to stop.
Yes. Just to show you the insertion of the trocar, the stiffness of the instrument, which is the same. And another small problem is when you grasp a membrane, you cut it because the instrument is a little bit not enough large to properly grasp the membrane, and you cut it. That is a problem. And so if you put on this video, you see an amyloidosis case where the vitreous is very quickly removed. It's an amyloidosis case. And I tell you that if you want to grasp a membrane with a 27 gauge, you have to create a fold with the membrane to grasp it in double, and so you can peel it in one part. I think the video is nearly finished. Yes, it's just to show you that with aspiration you can detach the posterior hyaloid. In this case, it's not triamcinolone but amyloidosis. And it's very convenient to detach the posterior hyaloid with the 27 gauge. It's very convenient, and if you want to peel the ILM, in this case of amyloidosis, you have also a nephroretinal membrane, and after the detachment of the hyaloid, if I want to remove the ILM, I show you that you can just break it a little bit at the beginning, and so you have to try to grasp in double, but you can do what you want, except in eye myopic. In practice, conversion to bigger standard is always possible, especially in case of intraforeign body removal, use of fragmatome, silicone oil tamponade, and in some extreme myopic case, 27 very similar to 25 gauge, 27 very short leaning curve if you come from the 25 gauge, 27 is immediately a mature standard, and the natural history of surgery is to simplify the surgery and to reduce the cost. In conclusion, 23, in my opinion, decreased a lot, 25 gauge remains the gold standard, and 27 gauge more and more. Thank you.
Okay. Shouldn't Guy go first? Okay. It seems to be reversed, so we start with Claude. You come later. Okay? Over to the red team and Claude.
Good afternoon.
Non, ça c'est un pointeur.
Oui.
La diapo suivante,
Oui,
c'est
mais
ça.
je sais. Je voulais essayer le pointeur.
Oui, mais si tu pointes là, ils verront rien.
Oui, alors.
Pointer, il faut pointer là.
Oui, c'est vrai.
Bon, allez. Okay.
Good afternoon. You know the principle of the flow control vitrectomy, which is that the pump self-adapts the vacuum to generate a constant flow independently of the variations of viscosity. For the sake of the understanding from many previous meetings, people told me that with the overlay on the screen of the console, it's a fantastic way to understand how it works. So I had to keep, for the first part of my talk, the movies done with my old machine, which was not the EVA machine. It was the previous Bausch & Lomb machine, which was a flow control machine. But it is very easy to understand how it works. because the vitreous has a tremendous variation, and especially when you are aspirating a mixture of BSS and vitreous gel, as you are dissecting here at the root of the posterior attachment of the anterior vitreous base. So you see that the flow is at 2 cc's because I decided it would be at 2 cc's. And you see the vacuum which spontaneously moves in order to provide me with a constant flow of 2 cc. The flow you can fix it, but it's the maximum, but it's linear control as well with the EVA machine. So you can also slow it down by moving your foot on the pedal. And then you have constantly, with a small delay, very small delay, what the surgeon wants to do according to the specific case. I picked up a case where the retina was not detached, not to add the problem of the retinal detachment, but just to show that even when it is attached, the vitreous viscosity, as you could see, entering the probe of the tip of the probe, is variable inside one eye, an individual's eyes. So how do I use that? I use that because it provides me a case-by-case evaluation of the ratio risk-benefit, which is tailored according to the individual viscosity. And most of all, it allows me to evaluate and treat the risk of anterior PVR. Let me just go back to PVR and the vitreous, what I call the vitreous factor. Actually, the modern concept of PVR, it is that it is a transformation of the RPE, which are epithelial cells, into mesenchyme cells under epithelial growth factor control. And it is a wound healing process which makes that those cells are able to build collagen if they have a collagen layer. This is how the viscosity of the vitreous gets increased. You see here in the porcine eye at 15 days, migration of RPE cells inside the vitreous cavity along the posterior hyaloid. And you see here an epiretinal membrane that we shall see more here with basically RPE cells, which you see are rhodopsin positive. They are migrated from the subretinal space, or they have transformed into macrophages with a little bit of rhodopsin, which was phagocyted. Actually, Yvette Ducournau, back to 96, showed those tunnels inside the Mueller cells, and this is a cell getting out of a hole into the internal limiting membrane. So here we have the case of a retinal detachment, and I identify intraoperatively a risk factor to develop anterior PVR, which means a tendency to incarceration inside the sclerotomy site when I check. And you see that I have to increase the flow up to 7 cc's with this previous machine, and that the vacuum was moving with a very low speed in order to allow this thick anterior vitreous band, which was close to the sclerotomy and might have been responsible for redetachment of the retina, to allow it to enter into the probe. We have one problem with the 25 gauge probes, is that sometimes you cannot do that because the rigidity of the probes is not enough, so you cannot bend always because you play around thing with the endoscope, and you cannot always bend and dissect completely where you want to do it with 25 gauge. Now the retinal factor In some patients, you have risk factor of developing tears. For example, here you have white without pressure in this patient operated for macular hole. And you see that here, I had to raise the aspiration flow. You're going to see I'm trying, but at 2 cc's I cannot. I have to raise it up. I think I remember up to 15 or 12 cc's with this machine in order to be able to grasp this so you see the viscosity was extremely high in this patient because I had to raise it up to 14 cc's, which normally you do at 2 cc's. Now, what is happening? So with the previous machine, at the normal anterior vitreous base, where you had no risk for anterior PVR, I had recorded that for a flow of 2 cc's, vacuum would be between 30 and 50 millimeters mercury. When there is a risk of anterior PVR, which I interpret it as a risk of anterior PVR because a higher viscosity, you see that your vacuum spontaneously raises up to 300 and 400. This means the viscosity of the vitreous is already very much increased. In case of an established anterior PVR, sometimes you have to raise the flow from 5 to 12, 15 cc's. And vacuum may spontaneously reach the maximum of 600 on this pump without being able, for example, to dissect cyclitic membranes. So this is a very interesting indirect indication of the risk of anterior PVR. Now, when you want to aspirate decaline, with this machine, I was used to have to raise the flow up to 12 cc's per minute. What has changed with EVA? The normal with a normal anterior vitreous base, it's between 20 and 50 millimeters mercury. With a risk of anterior PVR, vacuum can spontaneously raise to the same thing, but you have to. I'm sorry, there is a mistake. Sorry. It's like the machine is the same. I'm sorry, the same slide as repeated. So I'm sorry, I'm correcting. I'm sorry. So the flow can have to be increased from 5 to 12, 15 cc's. Vacuum and spontaneously reach the maximum. But for example, in decaline, you aspirate with a maximum of 8 cc's is enough. Now I'm going to show you complications which occurred during a vitrectomy with EVA and how it was managed. The big difference with the EVA pump is that the incrementation by the surgeon can be done from 0.1 cc to 0.1 cc, when before it was only from 1 cc from 1 cc. And the fact that you are faster to reach the maximum ratio benefit, the vacuum raises less high than with the previous machine, means you save a lot of time because you are faster to reach the maximum ratio risk benefit. And when you come to a dangerous area, you can increment from 0.1 cc to 0.1 cc, which is extremely subtle. So here we are in a vitrectomy for retinal detachment with a large tear. Unfortunately, there is no overlay, despite the fact I had asked it for years to DORC, but they didn't do it. And probably here you see that the vacuum was raising up spontaneously to provide me with 2 cc's, probably around 200 or 300. But you see that here there is a rigidity between the anterior vitreous base and the retina, because the viscosity is higher and the machine has a difficulty. I was at the end of the case. I was about to leave the eye, And suddenly, you see we're now in the pocket. I have withdrawn because the patient woke up. The anesthesiologist is not in the room, and as he's phoning, we cannot find him. So it lasted about 5 minutes in this situation when I was aware of the instruments. And when I reopened, this is what I find, because I probably heard something withdrawing very quickly. And you see that you are in the situation that you have to peel something very viscous, because the clot was very fast to make up. And you have to try to find the ratio risk-benefit between aspirating the clot, not eating the retina. And if you want to do a shaving at high speed, you're going to cut the clot all the time, but you're not going to aspirate it to take it out from the macular area. And you see that it's not easy, because you don't want also that the potential attachment of the clot of the fibrin would make that you tear the retina, which is the macula itself. So finally, I succeeded doing it. Really, it's probably possible to do it without the flow control, but I think, of course, that was a terrible accident to happen and so stupid, but I was in a safe position to manage it. So if you want to understand more about how this works, you can look at this article with the video online, and you have all the detailed explanations about the vitreous viscosity and how you deal with it. Thank you.
Thanks, Claude.